This is the human side of healthcare, where we explore all aspects of today's ever-changing healthcare environment. Brought to you by the Dallas-Fort Worth Hospital Council and featuring CEO Stephen Love with co-host Thomas Miller. Now, let's make healthcare human again.
Welcome to the human side of healthcare. You know, this time of the year, there are many religious holidays. And if you're spending time with your family celebrating, just remember, it's been a tough 2 years, and we want to focus and wish you good health during these holidays. You know, this show is the human side of healthcare. We're here to give you information to make informed choices on things affecting your lifestyle. And that's precisely what this show will do today. Help you make good choices so that you can have good health.
What we're talking about today is something that if you have teenagers in school, they have been exposed to this multiple times. And maybe you as an adult are trying to kick the habit and have been using this instead. We're talking about, obviously, vaping.
We're delighted to have with us today Dr. Andrew Miller, who's a pulmonologist at Texas Health Harris Methodist Hospital in Fort Worth. Dr. Miller, welcome to the show.
Thank you for having me. It's an important topic, and I'm excited to be able to share some information.
You know, to set the stage for our listeners, let's talk numbers just a little bit. Can you describe or estimate how many teenagers in the U.S. admit that they're using e-cigarettes?
So it's not extremely well known because teenagers, as you might expect, aren't always the most open and honest. But CDC data tends to suggest somewhere around 2 million teenagers in the United States are using e-cigarettes and similar products. Up to about a quarter of these will actually admit to it, but the actual number is certainly much, much higher.
And it's my understanding that most of these vaping products do have nicotine, which we already know is addictive.
Absolutely. So nicotine is profoundly addictive. If you look at older studies of mice, and they'll be fed food, water, and a choice of nicotine, or food, water, and a choice of drugs like cocaine or even heroin, they'll actually select the nicotine over some of those other types of illicit drugs. It's profoundly addictive. And so what's known about many of these e-cigarette type products and vaping type products, that not only do they contain nicotine, but the levels of nicotine are many, many times higher than most cigarettes. And we're talking on the order of 100 or more times higher. So people may think that they take a small puff of a vape pen and think they're only getting a small amount of exposure, but indeed a small puff may be the equivalent of 10 or 20 puffs of a cigarette. So it's not only do they have nicotine, but the amount and the concentration per puff is significantly higher in many cases.
And you mentioned in your answer about a vaping pen. I've looked at some of these products. Some of them look like USB drives, markers, watchers, pens, as you said. The marketing to young people is unbelievable. Would you agree?
Sure. I mean, I think they know what their target audience is, and they go after it. I mean, if you look back in the 1950s and 60s, it was candy cigarettes, and nowadays it's, as you say, USB drives or laser pointers or pens or everyday items that allows the teenagers to perhaps hide them in school in a backpack from their parents, and allows them to unfortunately use it surreptitiously in a way that I think people may not realize. And some of these products are actually dual use. What looks like a pen may be a pen as well as a vape pen. They can be taking notes in class and almost vaping at the same time, if you will. Same with the USB drives and some of the others, where they look like objects, but they actually might have dual use.
You stated about how a puff from a vapor could have much more nicotine than, say, from cigarettes. How do the vapors affect the lungs?
It's a great question. And I think to start off, I should say there's a belief that has been demonstrated and proven false, but a belief that vapors are somehow safer or safe at all, and that smoking a cigarette isn't. Without getting too technical, a vapor from a scientific or chemical standpoint is the gaseous form of, say, a liquid, but it's a pure gas. Smoke is something that is a gas but has small or fine particles in it. And anyone who's been near a forest fire or a campfire kind of knows that they get on you. You can almost feel them. And so when you combust a cigarette, that causes smoke, which when inhaled, you now have this gas, but also these fine particles that make their way down into the very base of the lungs, which you call the alveoli or the air sacs. Vapors, which people think, well, it's not smoke, there's no particulate matter, what's sometimes called tar, with cigarettes in them, it was presumed to be somehow safer, but the actual chemicals that make up the vapor are by no means safe, nor are they healthy for the lung. And unfortunately, as again anyone knows who's ever breathed in any vapor, whether that was from, if you walk into a salon, or any other location and take a deep breath, you immediately feel a tightness and perhaps even start coughing. And those are vapors. And so at the end of the day, the lungs are designed to have clean air in them, not other chemicals, not particulate matter. And so any of those chemicals that get into the lung, you can feel the reaction, and it has been well proven and shown to cause significant damage to the lungs.
Following up on that and the damage to the lungs, how would you say vaping impacts lung function and lung capacity?
That's a very good question. And again, I don't want to be too technical, but when the lungs are exposed to something other than clean air, could be you took a sip of coffee and went down the wrong pipe, as they say, could be certainly smoking, vaping, could be exposure to a fire, etc. But at any time you have a chronic or ongoing exposure to the lung to something other than clean air, the response to that in the lung is what we call inflammation. And that's similar to saying if I took some sandpaper and scraped it across your arm and then stopped, you would note that the skin would become red. It would become very full feeling. It might even weep or have some moisture. And if I did that every day, a couple times a day, eventually that skin would actually scar. It wouldn't be normal skin anymore. The lungs are just tissue the way the skin is tissue. And so if you cause a continued and ongoing damage to it, even if it's a few times a day, but a few times a day perhaps over months or years, the tissue can't regenerate and can't heal. It's very similar to any other organ in the body. People don't see the lung, so they don't necessarily know it until there's a problem. But the damage, again, whether it's a vapor, a gas and chemicals, or smoke, a gas plus particulate matter, the lungs still just view that as something that's causing damage.
This is Dr. Andrew Miller from Texas Health Harris Methodist Hospital in Fort Worth. And when we come back, the question, can vaping cause lung cancer? Straight ahead on the human side of healthcare.
This is the human side of healthcare, where we feature healthcare's hottest topics and what our North Texas area hospitals are doing to make healthcare human again.
Welcome back. Thomas, we're talking about protecting your lungs. Please don't vape. And one thing that'll help your lungs also is not to have COVID-19. And I mention that because we are seeing a slight uptick, not trying to panic people, but we are seeing a slight uptick in hospitalizations, primarily because of BA.2, that variant, the stealth variant. And so do everything you can to protect yourself and especially your lungs.
We're continuing our conversation now with Dr. Andrew Miller, pulmonologist at Texas Health Harris Methodist Hospital in Fort Worth, and starting with a very important question that anyone using these products should ask.
It may be early on in the process when we talk in terms of vaping. We know cigarette smoking can cause lung cancer. Do we have enough evidence that vaping can cause lung cancer?
It's a more difficult question because these are newer products. The fact of the matter is, in all likelihood, for what we've seen thus far, the answer is certainly probably yes. But if you take a step back from, say, even something as scary as lung cancer, smoking and vaping certainly cause significant damage to the lung and disease that is apart from cancers, what we call COPD or emphysema. It can exacerbate asthma. It can cause, certainly chronic cough. It can make you more susceptible to having more severe respiratory illnesses. And so, while I think it would be difficult to say this early on, because something like a cancer takes years to occur after, yes, there's no significant difference to the damage that is caused by vaping than we know is caused by smoking. So we would have to certainly presume that, yes, cancer is up there. But we do know that the other diseases that occur, COPD, emphysema, worsening of asthma, development of asthma, as well as just overall worse outcomes from any given respiratory illness, infection, etc., absolutely do occur. So it's I would say it's a much broader picture than even just cancer.
Asking you as a physician, how do we not only educate young people, but parents? And I'll explain to you why I asked that question. I was actually talking to a parent the other day that said, my kid's vaping. I'm so glad they're vaping and not smoking cigarettes because there's no nicotine in vaping, which of course I told them you're wrong. It's very serious and it's something that you should address. What's the best way to educate people? Do you have thoughts on that?
Certainly. I think, first is what you described is step number one, right? Which is just starting a dialogue with someone and being open to what they may not know. I think sometimes people think, they might feel uneducated or stupid, and they're not. People don't know, and there's a lot of bad information out there. Even the people who realize that there is nicotine, as we talked about, that the amount of nicotine is different. And then I've heard some of my patients say, well, nicotine isn't what caused the problem. It's the tar, it's the combustion that causes the problem. And the answer is that's not fully true. And also, there are other chemicals in these vape fluids other than just nicotine. The nicotine is the addictive chemical, but there are many other chemicals. And so these chemicals absolutely cause damage. In fact, there is a disease called EVALI, E-V-A-L-I, or e-cigarette vaping-induced lung injury. And then this was first named in 2019. Throughout the country, scores and scores of young people, teenagers, young adults, coming in with a very severe lung damage, in some cases life-threatening. There was a lot of ongoing effort to figure out what the heck is going on. Was it an infection? Was it a new environmental toxin? But there was something happening. And it was this, what is now termed EVALI, and it was directly caused by vaping. This is, again, right before COVID. But during this time, it was fascinating because these young people would come in, and they knew all about it, and they'd be on their social media apps and Facebook and Instagram and others, hearing about it, and they would, to a person, say, well, I'm going to get on there and tell people to stop. And over about a few months, it was all in the news, and a lot of the young people started to get the word out that this is causing a real problem. And again, in many cases, life-threatening with some permanent damage in some people. Then COVID happened, and I think that actually took some of this out of the news. But opening up a discussion about it and talking about the fact that these things do have damage, that they are different than cigarettes, and they may cause damage in different ways than cigarettes. But that's kind of like saying, would you rather be shot in the chest or shot in the arm? I mean, either way, you don't want either of those things. And so though the mechanisms may be different, the end result is the same. And lastly, I'll say, doctors throughout many different hospitals studied extensively, hoping, in fact, that we could use vaping to help people quit smoking cigarettes. That was a hope about 10 years ago when all these things first came out. And there was a hope that they were safe. In fact, they were already existing, and many studies have been performed in many centers, not just in this country, but around the world. They've demonstrated that not only are these things damaging, but they also don't help people quit smoking. Believe it or not, people just become addicted to the nicotine that's in the vape. So it's a very complex situation.
You mentioned in your answer where some people try to rationalize it's not the nicotine, it's the tar and the other substances that really cause the damage. And you certainly pointed out how addictive nicotine is. But if we look at adolescence, isn't brain development impacted by nicotine?
It is. And that's, again, very well known. And very well described over decades at this point. Brain development begins in utero, and really the first 9 months, the baby's brain is really still forming, but the brain is actually still developing until about age 25, and in very significant ways. And so nicotine, which is a potent neurotransmitter, or at least it binds to an area in the brain that way, is extremely not just addictive, but has direct effects on the body at the central nervous system in the brain. Smokers know this. Smokers learn this naturally. Anyone who has ever smoked will tell you that when they're nervous, they smoke slow and they take slow draws. When they're happy and about to do something fun, they may take a few quick puffs. And what they've learned naturally is that if they get high levels of nicotine quickly, it actually stimulates them. If they get lower levels of nicotine slowly over time, it actually helps to calm them down. These are potent chemicals that have absolute effects in the brain and on the developing brain. And again, one of those topics that I think I certainly never understood before I was a doctor was the fact that again, the brain itself really is developing in some ways up to and beyond even about age 25.
We've talked a lot about e-cigarettes and vaping, but there's also some other products out there. They're referred to as heated tobacco products. Some people call them HTPs. Parents need to be aware of this. Kids need to be aware of this. How do you differentiate as a physician between HTPs and e-cigarettes?
So clinically, again, the safety, or I should say harms, are all indistinguishable effectively. How they're different is the fact that, again, vaping is taking a liquid or a fluid and turning it directly into a gas. These quote unquote heated tobacco products are exactly what they suggest to be. They heat direct tobacco leaf. They don't necessarily state that they actually burn it, but they heat it to actually have some of the chemicals come off. And again, this has been purported to be a quote safer form of getting nicotine or smoking, what have you. And the answer is, for all the reasons that we talked about prior, is not only less safe, it's just unsafe. And it has all of the same effects downstream that any of these other products do. Essentially, anything that might be purported to be a quote safer way of smoking is just not. And again, we can always look back to history. I was a history major myself, and if you look back at the history of cigarettes, right? People rolled their own, then they had manufactured cigarettes, and long about the early to mid 60s came with filtered cigarettes, and that was a much safer way to smoke, it was said, and it made no difference. And so what we're seeing today is history not repeating but rhyming, as always. And it's just going to be more and more ways of people being told, here's a quote safer or even safe way to do something that is just unfortunately unsafe. And the people who are always going to be most harmed are teenagers, because they haven't been around long enough to really understand the bad effects these things have.
This has been Dr. Andrew Miller, pulmonologist at Texas Health, Harris Methodist Hospital in Fort Worth. Thank you for those excellent comments. They are also on our podcast, The Human Side of Healthcare. Now, what if you do get lung cancer? The latest diagnostic and treatment techniques next on The Human Side of Healthcare.
Welcome back to the human side of healthcare, where we explore how to take better care of your health so you can live a happier, healthier life. With DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
Welcome back. We just talked about protecting yourself and protecting your lungs. Now we're going to talk about treatment, especially if you have lung cancer. We're delighted we've got with us Dr. Tony Sue, who's a pulmonologist and the medical director of the lung cancer program at Texas Health Arlington Memorial Hospital. Dr. Sue, welcome to the show.
Thank you, Steve, for having me this afternoon.
You know, for our listeners out there that may not be familiar with some of the trends in lung cancer mortality rates, can you fill us in on what's been happening over the past few years?
Absolutely. Lung cancer mortality has actually decreased quite dramatically in the last 20 to 30 years, especially for men. It's decreased by 50% since the 1990s, and for women, it's decreased about a third over that same period of time.
So what do you think has caused this decrease?
There are probably several factors, but the most important factors include smoking cessation, of course. There's less people smoking than in the past. That's one thing. The other things are related to lung cancer screening programs and advances in treatments such as immunotherapy and minimum invasive surgical techniques.
You know, you mentioned some of the screening programs. For example, I know men get their PSA checked as an indication of prostate cancer. But for lung screening, what exactly do you go through and how are you screened?
So for patients that are high risk, and high risk being a smoker, a current smoker that is age 50 years or older, who quit smoking maybe 15 years ago, people that have smoked a pack a day for 30 years, what we call 30-pack year history, or a family history of lung cancer. The way to actually do the screening is low-dose CT scanning on a regular basis, kind of like a mammogram for breast cancer.
You know, that's a good analogy about a mammogram. So let me ask you this. We know smoking is certainly making you high risk, but can lung cancer be hereditary? Family history come into play?
It certainly can. In fact, I have a personal family history of lung cancer. I have an aunt that basically developed metastatic lung cancer, and there's no a relationship with people that have been smoking around her, and as well as a family history of emphysema in other smokers. So not only a family history of smoking or a cancer, but also secondary exposure to cigarette smoke.
And I'm assuming, especially for a lot of the young people out there listening, vaping is not good for your lungs either. Would you agree?
Yeah, I definitely agree with that. Although the incidence of smokers have gone down steadily over the last several years, there's less adult smokers than before, we have seen in the younger adult population an increase in vaping. And the problem about vaping is that we don't know what kind of chemicals are being burned during the vaping process. It's totally unregulated, and there are some harmful chemicals that are being emitted from the vaping itself. So the jury's out on vaping, but it's probably just as bad as cigarette smoking, if not worse.
You know, I know we think in terms of cigarette smoking and lung cancer. Are there other environmental external factors that can impact your lungs?
Sure. The one that we deal with quite a bit here in the Metroplex is actually pollution. So on ozone alert days, that certainly has something to do with irritating the airways of the lungs and developing possible bronchitis or asthma or even lung cancer. The other thing that is tied to lung cancer that's not related to cigarette smoking is radon gas exposure. So that's an environmental thing. So that sometimes we can't get rid of that because we don't know if there's radon that we're being exposed to.
You know, if you had a person come in and they went through the CT scan, as you mentioned, and you noticed nodule or nodules, what happens then?
When a nodule is detected by, let's say, your primary care doctor, they did a CT scan screening because you're an ex-smoker, you are usually referred to a pulmonologist, such as myself, and we do a thorough evaluation of your situation, and then most likely, if it's large enough, we go ahead and pursue some type of tissue sampling.
So you would do some form of biopsy. Is that the needle biopsy done through the rib cage, or are there other types of samplings?
Sure. The CT guided needle biopsy done by interventional radiologists is the ones that's done through the rib cage. So the patient is put into the CT scanner, and the lesion is localized by the imaging, and a needle is passed through the rib cage into the nodule. The other techniques of sampling a nodule include bronchoscopy and excisional biopsy by thoracoscopic surgery.
You know, if you have a patient come in, and I know each patient's different, and you do the biopsy and you detect cancer, what are some of the treatment options?
The treatment options for lung cancer range from a possible curative intent by surgery, if it's small enough and you are actually well enough to tolerate the surgery. The other options, if you're not able to tolerate removal or excision of the lesion, then there are chemotherapy, radiation treatment, and the newest treatment is immunotherapy.
Can you expand a little bit on that?
So immunotherapy is very interesting. So these are usually monoclonal antibodies that recognize certain proteins on tumor cells themselves. So it's not like chemotherapy where you basically target rapidly growing cells, and the chemotherapy kills rapidly growing cells, and that's how it works. But immunotherapy actually attaches the monoclonal antibody to the tumor, and that kills the tumor cells directly. So it's safer and it's less side effects.
I know we talked about how the screening has helped in the mortality rates related to lung cancer. Would you say that the life expectancy once diagnosed has increased with some of these new treatments? What are your overall thoughts? So if someone is diagnosed with lung cancer, they know that there are very viable options for treatment.
Yeah, and if you detect lung cancer at early stage, you have a greater than 90% survival rate at 3 years out. That's incredibly encouraging. If you diagnose lung cancer at a later stage, then your mortality of course goes way up, and your survival rates approaches 20% instead of 90%.
Are there any conditions that you could have related to the lungs that you have to really monitor for fear that it could develop into lung cancer? Let's say someone has COPD. Are they at risk to develop lung cancer?
Yes, in fact, that's probably the highest comorbidity that we see. So people that have COPD are much, much higher risk of developing lung cancer than someone, let's say, that has just asthma.
You know, we've been dealing with COVID-19 for 2 years, and I know you specialize and you're the medical director of the lung cancer program. But are you seeing in your role as a physician people having permanent lung damage because they had COVID-19?
Sure. What I've seen is that most people that have COVID-19 do recover and they don't have what we call COVID lung damage. There's a handful of patients, and we don't know who will get COVID lung damage, but they have terrific scarring and they are more prone to having secondary bacterial pneumonias, or they have collapsed lungs, and they just don't do well. And they may be on chronic respirator or chronic oxygen therapy. So it's not as bad as most people believe it to be, but I do see a handful of patients that have permanent damage from COVID.
I'm not being judgmental of people's lifestyle, but I do want to ask you this, and you as a professional and as a physician, we know that smoking cigarettes puts you at risk for lung cancer. What about smoking cannabis?
Cannabis is kind of like vaping. There's not a whole lot of studies out on smoking cannabis. As we accept cannabis in society as a recreational drug or even a medicinal treatment, I believe that you'll probably see a higher incidence of lung cancer developing cannabis users.
Dr. Sue, you've done such a great job answering the questions, especially to our listeners, and let's say young people out there that are considering smoking their first cigarette, etc. What is you as a physician would like to relay a message to our listeners on how to best protect their lungs?
Well, the best thing to do is if you're smoking, quit while you're ahead. And the other thing I would tell people is it's never too late to stop smoking. So let's say for lung cancer, if you stop smoking today, it will take about 10 years to decrease your risk of developing lung cancer to that of a non-smoker. So it takes 10 years to get rid of the risk to a non-smoker cancer rate. So it's a bad habit. We do it, and unfortunately, we have consequences if we continue to do it.
We're talking with Dr. Tony Sue. He's a pulmonologist and the medical director of the lung cancer program at Texas Health Arlington Memorial Hospital. If you missed our earlier segments with Dr. Miller about vaping, we have all of today's conversation on our podcast, The Human Side of Healthcare. When we come back, can non-smokers get lung cancer? Next on The Human Side of Healthcare.
This pre-recorded program is paid for by the Dallas-Fort Worth Hospital Council.
Covering the healthcare topics that matter most to North Texas. This is the Human Side of Healthcare with DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
Welcome back. More now with Dr. Tony Sue. He's a pulmonologist and medical director of the lung cancer program at Texas Health Arlington Memorial Hospital. And just a reminder, we do have a podcast, all of our interviews in their entirety in the podcast, The Human Side of Healthcare. It's on all the major podcast players. We've seen a lot of reports lately of non-smokers coming down with lung cancer. Can you just comment on what's going on there?
So, we don't know exactly why patients develop lung cancer that are non-smokers. Some of them has to do with environmental exposure. So maybe perhaps the spouse or a parent used to smoke. But there are certain familial risks for developing cancers. So there's sometimes cancer families. So a mom might have colon cancer, and then the son might have lung cancer. And there's no rhyme or reason for them to have it, except they have bad genetics that for some reasons the mutations occur in the tissue that causes them to develop a malignancy.
You're talking about cigarettes as being the number one cause, obviously.
Yes, 80% of lung cancer can be explained by either current smokers or ex-smokers. That's quite a big number.
This is kind of out of the Scared Straight playbook, but tell us what's in cigarettes that causes this development in our lungs.
So I believe it's due to chronic inflammation from the tobacco products that are being burned. So, you have the tar and you have the nicotine that people talk about. If I looked at a smoker's lung through a bronchoscope, it is not going to look pretty. The tissue is pale. It could be dark with brown phlegm. It's just dirty looking bronchial secretions. It's just not a very pretty sight.
Do you know what chemicals are in there as well? Because there's a ton of chemicals added by the tobacco companies.
Yes, there are a lot of chemicals. I can't name them off the top of my head, but anytime you have, combustion of organic material, you have all these chemicals that are just basically promotes inflammatory process in the lungs. But as far as the chemicals themselves, I can read off a list, but it doesn't mean anything unless it's to a chemist. So,
patient comes in and says, "Doctor, I want to quit." What do you tell them?
So we use a multi-pronged approach for smoking cessation. So there are smoking cessation aids. nicotine replacement therapy, such as the gum, or there are medications that decrease your craving. And then there's also very important counseling and just talking about, hey, did you stop smoking yet? Every time the patient comes to see me that is a smoker, I always ask them, are you still smoking? When do you plan to quit? Even that helps in terms of quitting smoking. And most people that quit smoking, if they have tried in the past multiple times, they're more likely to quit.
Do you know why somebody would inhale that substance into such a vital organ of their body?
I don't know. When you're young, so when you're at age 25, you have your best lung function in your life at age 25. So that's when most people are smoking. If they ever become a smoker, that's when they start. So they feel that they're invincible. Nothing's going to hurt them. Of course, they have plenty of lung function. As we age, our lung function will naturally decrease. And if you're a current smoker, your lung function decreases a lot faster than somebody who never smoked. So when some people quit, the damage has been done. I have had patients that smoked for 50 plus years. They quit smoking maybe 15, 20 years ago, and then developed their emphysema or their lung.
You mentioned 10 years basically to reverse the effects of smoking. Is there anything that could expedite that? Can people do anything to help improve their lung condition and resist cancer after quitting?
I don't think of anything particularly, besides decreasing the exposure to cigarette smoke and having a healthy lifestyle other than proper diet and proper exercise. And part of developing lung cancer is genetic, so you can't choose your relatives. There's nothing specific. The thing that has decreased mortality in our lung patients is two things. One is smoking cessation, and the other thing has been oxygen therapy. Let's say you've damaged enough lungs that your emphysema is so bad, well, oxygen therapy will increase your survival rate. But smoking cessation is the number one thing that you can do for your lungs.
I had a friend pass away of lung cancer last year. He never could put the darn things down.
Right.
But it was detected at stage 4. And it seems that to us lay people that lung cancer is often detected after it's too late. You talked about early detection. What should be our guidelines of how often we should check?
Sure. If you're at high risk for lung cancer, early detection is the key. And so when you're in the lung nodule program, and we will screen you on an annual basis if you're at high risk. So let's say your CAT scan shows no nodule the first year, but we'll screen you because you're still at that high risk category unless something changes. If something changes, then we pull the trigger and go for a biopsy of the spot that might have popped up. It is true that most people that come see me that have symptoms of lung cancer, whether it be weight loss, coughing up blood, shortness of breath, having chest pain, it's usually in the late stages. So early lung cancer is asymptomatic. You have no symptoms. You have no clue that it's inside of you. So if we can detect things earlier, we can do what we call stage shifting. We shift the stage of cancer from a higher stage to a lower stage. Lower stage means early detection, early diagnosis, early treatment. And in our lung program at Arlington Memorial, we actually, our goal is to diagnose lung cancer and get them to definitive therapy in 30 days.
Wow. How long does treatment last if it's successful?
The best treatment for lung cancer is to get it when it's small and to cut it out. So if you have a small tumor that we diagnose with biopsy, and we refer you to, let's say, a surgeon, a chest surgeon, and they decide that you're a good candidate to have surgery. Basically, if they do an excisional wedge resection of the lesion, then you're considered cured.
So that's the deal then, is once it's advanced up to the higher stages, it's spread. It's gone wildfire at that point.
Right.
Is that it? Is that
Right.
the deal?
Yeah, so you have a large tumor burden. It may be metastatic disease to other organs. So lung cancers like to spread to certain organs, such as liver, adrenal glands, brain, and bone. And so it's harder to treat cancers when it's spread like wildfire. Too many fires. How do you put out each fire?
All right. I'm going to put you on the spot. All right. 60, 70 years ago, doctors used to advertise for cigarettes. These are the cigarettes we doctors choose to smoke. What does a current contemporary doctor think about that?
We think it's quite humorous. I mean, I know of certain physicians that click those ads. It's smooth. It soothes the throat. Now we know that causes laryngeal cancer too. But that's all marketing. To selling tobacco products. I mean, there was cocaine and coke a long time ago. Come on. So yeah, a contemporary physician is saying, well, yeah, that's history. We should learn from history and not repeat it. And so we know a lot more about what cigarette smoke do to your health now, and not only in lung disease but cardiovascular health and blood flow to your organs, your brain, to your legs. And bladder cancer is associated with cigarette smoking. So there's a lot of other medical problems that we are much more knowledgeable about than we did, 60, 70 years ago.
It's just something that wasn't studied, was it? It was common, it was social, it was part of our society, and medicine just hadn't caught up with it yet.
That is correct. And so the same thing when when our veterans came back from World War II. And everybody, during the war, got as part of their rations, they got a pack of cigarettes. And we have a bunch of veterans in our VA hospitals that have emphysema, COPD, chronic bronchitis, and lung cancer. And luckily, the lung cancer mortality rates have gone down, especially for men. That's incredible to drop by 50% in 30 years.
We've been listening to some excellent updates on lung cancer from Dr. Tony Sue, a pulmonologist and medical director of the lung cancer program at Texas Health Arlington Memorial Hospital. Thank you, Dr. Sue, for joining us. Steve?
Thank you for being with us today. Remember, BA.2 variant is still out there. Please be safe and join us next Sunday for the human side of healthcare.